So I think we are being live streamed. So good evening, everyone, and thank you for attending this special CME that the pediatric rheumatology, pediatric hematology teams have, come together to present this interesting two-case series today, and we have named it the Genome Huddle. So, a lot of clinical medicine that we practice is now at the crossroads of hematology. Just a second. I have some, one second. Yeah. Yeah, I'm back there. Sorry, some domestic issue. And, I had to just rush to rescue my kid from a centipede. So it's all sorted now. So, yes, so, a lot what we do in our clinical medicine comes at a crossroad of pediatric rheumatology, immunology, pediatric hematology, oncology. And, with the field of genetics just really growing at a very fast pace, sometimes we come across with these very difficult reports that are very hard for us to interpret, and how to make that clinical scenario merge with the report, and whether those reports are really helping us guide further future treatment for these patients is what we are trying to learn. And in the last few years, I think the genetic sequencing being easily available for us has completely revolutionized, and also at times made our lives quite tough. So, and as we are trying to learn genetics more and more, we have an expert with us today who is a pediatric rheumatologist and has also worked in the field of autoinflammatory disorders, Dr. Pallavi Pimpale, who's kindly agreed to be our special guest and speaker for today's webinar. And thanks, Pallavi, for doing that. And I would say that let's hope that, we look at our clinical cases that we have to present today, interpret them with the genetic and the immunological aspects, and see how we are whether we are wiser or not in managing our patients with these difficult case scenarios. So I have Dr. Sujata Sani with us, whom I really admire, a teacher par excellence, and I sit with her every day for 5 minutes to get some gyan in immunology, rheumatology, hematology, and also life. So, and thanks, Abe, for sharing your very difficult case with us. And we'll see how, all of us together have managed that patient, and, what surprises life throws at us. And we will start with the first case, which Dr. Sujata Sani will be presenting, and the second case, which Dr. Abhay will be presenting. And we'll request Pallavi to please feel free to interrupt and give your comments. And we really want to learn from each other. And for the audience, I request them to put their questions in the chat box so that we can take those questions at the end. So over to you, Dr. Sujata, for the first case.
Thank you so much, Manas. If you can put up the slides, please. So thank you everyone for joining in this. I think this is a very exciting meeting, and hopefully it's going to help all of us to look after our patients better. And as Manas gets the slides up, just very recently at the last Indian Rheumatology meeting, we had a very smart young fellow working with us from adult rheumatology for a few months. And Dr. Hiren was absolutely wonderful. He looked at our data of whole exome sequencing that we had ordered, and we looked at the whole exome sequencing of 70 consecutive patients. So we looked at the whole exome sequencing of 70 consecutive patients. And what did we see in these patients? Next, please, Manas. Next. So the results of a whole exome sequencing throwed up exactly what we are seeing today. And we saw that of the 70 exome sequencing we had requested for our patients, broadly speaking, about 40% in the yellow in the yellow display here were normal. 24% of these patients had exome sequencing that threw up a pathogenic gene. 6% were likely pathogenic. And we had this whole bunch, 1 in 3, 31% that had uh, variants of unknown significance. And this then is the most complicating feature because we are not sure whom to approach, how to take this forward. Shall we get a trio sequencing done? We need a functional assay. We don't have a lot of that in Asia. And whom do we turn to? And not only that, looking at the clinical phenotype, we saw that less than half of our patients had a genotype phenotype correlation, and more than 40%, nearly in fact 60%, did not. Next. And when we looked at the variety of patients that we had ordered a whole exome sequencing for, we found that in these little bars here, the ones which were just 1 or 2 cases each, we were pretty good in looking at the clinical phenotype and matching the gene with it, and that was the arthritis variants. If you look at the bottommost yellow bar where we suspected inflammasomopathy, we were able to confirm it in very few patients. Our hit rate for DARA2 was not bad at about 50%. And then you have a smattering of the other clinical diagnoses that we had. Next. So this little story about the whole exome sequencing from our own unit tells you that VUS can be a very big issue in our clinical cases. And we are going to present for you today 2 interesting cases. And let's start with the first one. Next. So this is an 11-year-old female child of Iraqi descent who came to our medical attention in 2023. She had been unwell for 2.5 years prior to presentation, and she had come with recurrent episodes of bone pain and swelling. And she had reported pain over both the shins with swelling, which occurred sequentially several months apart, and also a painful swelling of the left radius, so that this patient had indeed had 3 osteotomies when she came to us, and each biopsy had shown chronic active non-specific osteomyelitis with no granuloma or malignancy. And this patient had had a bone scan done prior to coming to us, which showed uptake in several bones, including the maxilla, the mandible, the ulna, and the tibia. And this patient, much like an NBO or a CRMO patient, was having episodic painful swelling of the bones, and the biopsy was inflammatory. Next. So based on this diagnosis, this child was given a working diagnosis of CRMO. However, something that struck us in our unit was that this child had a very long segment diaphyseal involvement. And for my hematology colleagues, when patients present to us with non-infectious osteomyelitis, most of these children are likely to have a metaphyseal involvement. Diaphyseal involvement is described, but not very long segment diaphyseal involvement, which is what this patient had. So we did consider a autoinflammatory phenotype in this patient, which could have been monogenic, and we asked for a whole exome sequencing for this patient. Additionally, because we had biopsy evidence of inflammation, we went ahead and started this child on methotrexate and bridging steroids. And the father reported to us when he came back to us in July 2025 that this patient was actually remarkably better. She only had mild pain that was quite well controlled. She'd come off the steroid and was maintained on methotrexate. Next. She'd had a lot of testing done prior to coming to us, and you can see that she had a moderate elevation of the ESR. She had some elevation of the C reactive protein, and other parameters were broadly within range, and there was nothing majorly abnormal in these parameters. Next. The only thing we noticed is of late that this patient had an elevated serum phosphorus. Everything else appeared to be normal. Next. And this is the imaging of this child prior to coming to us. An MRI showing you long diaphyseal involvement of the tibia. Another CT scan at another point in time which showed involvement of both the tibia. Next. And when she came to us recently, about 6-8 weeks ago, we got an whole body MR done, and you can see she's got a mild uptake in the mandible, and had reported that she had some pain around the jawline a few weeks prior to coming to us. Next. So we thought this patient had chronic non-bacterial osteitis. Were we right or wrong? And here's a new classification criteria from the UR and ACR, which has just been published a few months ago. And they talk about an entry criteria of age being less than 16 years, bone pain more than 6 weeks, and fairly classical X-ray and MRI changes. And this patient had all of them. And very interesting, they don't talk about the site of bone involvement, epiphyseal, metaphyseal, or diaphyseal, no discussion. And they say very clearly that you need to have excluded the following differential diagnoses in your patient, and there's no mention of serum phosphorus or looking at the PTH bone axis. The only thing they talk about is hypophosphatasia, which is a lowered alkaline phosphatase, which can present with bone inflammation mimicking children with non-bacterial osteitis. And you're aware that the classic non-bacterial osteitis is a polygenic disorder, and no particular gene has been discovered to cause this disease thus far. Next. And the ACR-ULR criteria of 2025 have today given a weighted score, as is very common in many of our pediatric rheumatic diseases. And you can see that there are several features one has to take into consideration, including the bone biopsy, the age of onset of symptoms, suggesting that if the child has disease onset under 3 years of age, it's very unlikely to be a polygenic disorder like NBO. That the site of imaging, very classic, is clavicle or mandible, and that scores the highest points. When you look at the distribution of bone imaging, if you have symmetric bone involvement, that is to say bilateral involvement of at least one bone, you get the highest score. If you have other conditions that go along with CNO that we all know about, such as inflammatory bowel disease or palmoplantar pustulosis or axial arthritis, you get points accordingly. This condition is not associated with a very lowered hemoglobin, and these patients don't have significant fevers. The ESR and CRP are moderately elevated. The score suggests that if you have more than 55 points, then you have a very high likelihood of having NBO. And indeed, our patient's score was 83. And this scoring system has a specificity of 98%. Next. And I'm sure you've guessed as the story unfolds that this patient did not have non-bacterial osteitis. We had ordered a whole exome sequencing for us, and we got this report and frankly kept it by the wayside because it said it was of uncertain significance and the GLNT pathway never existed when I did clinical medicine, pediatrics, or pediatric rheumatology. And I didn't really think that this patient, at a cursory glance, had any features of familial tumoral calcinosis. But then, when this patient came along to us and we got routine evaluation and found an elevated phosphorus, I decided to dig deeper into this. Next. Okay, so then let's look at this very interesting pathway, the FGF23 GLNT mutation that can cause bone inflammation. Next. So this took me a long while to read and several reads indeed. So I'll try and make it very, very simple for all of us. And on the panel above, you have what happens in normal individuals. And here in the lower panel in blue, this is what happens in disease. So within of the osteocytes, we have a fibroblast growth factor 23. And this fibroblast growth factor 23 is secreted when the serum phosphate is high in the body. And when the serum phosphate is high, the FGF23 is secreted. Now, the FGF23 should be secreted in its intact form. And for it to remain intact, it's very important that this FGF23 be glycosylated by a gene that is called the GLNT3 gene within of the Golgi apparatus. If in case the FGF23 is not glycosylated at several specific points, then this FGF23 is liable to be disintegrated via several proteinases and FGF23 activity then drops. Now, what is the role of this intact FGF23? The intact FGF23 will go to the proximal and the distal convolutal tubules of the kidney, and essentially it causes phosphaturia. And when it causes phosphaturia, the serum phosphorus will obviously come down. So that's the way the FGF23 works. Now, for the FGF23 to work, it has to go and attach to a receptor, which is the FGF receptor complex, which has a co-receptor that is peculiarly named Clotho. Now, what we need to understand is that if in case there is a mutation that is reducing the activity of GLNT3, the intact FGF23 will reduce. If we have a genetic abnormality that is producing FGF23 and FGF23 itself is reduced, or if there is a genetic defect in the Klotho complex, all of these are going to prevent phosphaturia and the serum phosphate is going to go up. And that's what the panel in blue shows us here, that loss of function mutations in FGF23 or the GLNT23 or the loss of function of Klotho all are going to increase the serum phosphorus, and this calcium and phosphorus are then going to increase in the serum and get precipitated in the largest reservoir of calcium and phosphorus in the body, and that is the bone, and that is what causes the inflammation. Now, at lower levels or with abnormality of the GLNT3 gene, we get, next slide please, a syndrome that is called the HHO syndrome, which means hyperostosis, inflammation of the bone, hyperphosphatemia, elevate phosphate level syndrome, the clinical constellation that occurs when there is involvement of the long bones and inflammation. It is thought and not very clearly understood that if the FGF23 genetic pathway is directly involved, then that calcinosis which occurs in a heterotopic fashion tends to occur around joints and around vessels, such that HHO and familial tumoral calcinosis are two sides of the coin when we have abnormality in the FGF23, GLNT3, and the Klotho pathway. Next slide, please. And it's very important to reach the correct diagnoses because unlike giving an NBO patient steroids, methotrexate, bisphosphonates, or anti-TNF therapy, we have to in fact direct our energies at reducing the elevated serum phosphate. Next. So what we learned from this particular patient is that our patient very easily was classified as having chronic non-bacterial osteitis. The metabolic pathways suggested in the recent paper are to exclude scurvy and hypophosphatasia. We believe that we must look at serum phosphorus in all these patients and that the presence of long diaphyseal segment involvement of multiple bones with increased serum phosphorus, low FGF23, and normal vitamin D should all point in the direction of an abnormality in the FGF23 GLNT Klotho pathway. So with those few words, I'll hand over back to Manas.
Thank you, ma'am, for presenting this case. And, you know, indeed, such cases present to pediatric hematologists also because, you know, we would be ruling out cancer in these patients because of these bone pains. And I think all these kids would undergo a marrow, maybe a PET scan because people are not able to figure out why there are so much bone pains. And I think bone pain is a very important feature of cancer, which is much common than these rare disorders. And ruling out malignancy in such cases is very, very important. Pallavi, Abhay, would you like to comment on this case before we move on to the other case?
This is an excellent example. Whenever you find any atypical finding in a described, it's a way to go ahead with genetics being little affordable now, going ahead with that. And most important thing that I learned is getting serum phosphorus because that's not what we routinely do in our CNO patients, even if they have some atypical findings. So that's my next go-to if there is some atypical finding on the MRI for my CNO patients.
Abhay, any comments from you for this case?
No, just that what ma'am mentioned makes sense, right? Whenever there's something unusual, it was not the metaphyseal involvement in this particular case. So you would have to have your antennas or alert so that you're thinking of, you're not missing out other things such as this. Of course, genetics has made things much easier, but like you said, sometimes more complicated as well.
Sure, thank you. Dr. Sujata, you want to make any final comments about this first case and before we move on to the next one? You're muted. You're muted.
No, I think that's fine, Manas. Thank you. We can move on to the second case. And maybe what we can do is take all the question and answers at the end once we
Sure.
come to Pallavi and a discussion. Perfect. Thank you.
Sure. So the second case is also a very interesting case, and you know we really were it was everyone's a nightmare to manage such a case because we had no answers for this very young child with very difficult, clinical spectrum with which she was presenting. And essentially, one could call it as a pure hematological presentation, but really we had no answers for this patient. So I now request Dr. Abhay to present the second case, and I also request the MKO team to kindly make Dr. Mridna also one of the panelists so that she can follow it up with the same patient's clinical history at our hospital. If you can make Dr. Mridna as one of the co-panelists. So Abhay, over to you for the interesting second case.
Thank you, sir. Are my slides visible?
Yes, yes.
And you can see the next slide, right? Okay.
Yeah.
So this was a very interesting case who came to us a few months ago. A 15 months old female child born out of a non-consanguineous marriage, no previous hospitalizations previously well. The onset, I think saw her first in June. The onset dates back to March 2025 when she had this kind of nodular swelling on the philtrum area. And she was being managed surprisingly by a surgeon who had ordered an MRI of the face, which suggested some hemangioma of the upper lip. The position was not very too much in keeping with the MRI findings, uh, the uh, but the swelling kept going and coming. So this child also had fleeting subcutaneous non-tender nodules over body, which we had not seen. The father did not have any pictures at the time. And when we saw the child initially, there were one or two CBCs in which the absolute neutrophil count was quite low. And there were four CBCs, out of which two of them showed low neutrophil count and two had normal CBCs. And the child had received multiple courses of oral antibiotics and steroids. The surgeon also felt this could be an angioedema, and the swelling had responded, but we were not sure exactly to what medication. So the surgeon actually gave on and off steroids, and the child got better. She gave on and off antibiotics, the child got better. During April and May, the father says that the episodic philtrum swelling continued. The fever history was not very clear. And like I said, we had four CBCs before the child came to us with a gap of 3 to 4 weeks. And two of them showed a very low neutrophil count, and two of them had normal hemoglobin, platelets, WBC, everything. So when we saw the child for the first time, she presented with fever, reduced oral intake, dullness, and that time she had the neck swelling, membranous tonsillitis, and cervical lymphadenopathy. There was no obvious organomegaly, but the neutrophil count was quite low. I'll come to that in the next slide. The child was admitted. And this was the child's photo when she came to us. So the swelling was significantly better actually when first saw her. And this was the kind of the subcutaneous nodule which we saw when she came first to us. And the father showed me some pictures from his phone. These are all at different timelines. And looking at the rash and these nodules, I also wasn't, I thought, could this be an LCH kind of a picture? Very unusual swellings. So we did an X-ray of the skull, which was normal. And then we did the CBC and the routine tests. So I'll just show you the day 1, day 3, and day 7 CBCs. Basically, when the child came to us, the hemoglobin was 8.6 and the neutrophil count was 3% with a 92% lymphocyte count. The platelets were normal. We all can see the day 1 CBC right now. ESR was 120, CRP was high, the procalcitonin was also high. The ferritin was in the range of around 1500, the LDH was normal. So I was pretty sure that this is not my case, nothing to do with rheumatology because of the very low neutrophil count. So I advised them a bone marrow and to get admitted under the hemonc team and the general pediatrics. And we all managed the child together. So the general pediatrician, the pediatric hemonc, and myself. The blood film showed moderate hypochromia and isocytosis, microcytosis, marked neutropenia. The bone marrow was done. Prior to this, the steroids were received. There was a gap of almost 3 to 4 weeks before the bone marrow was done. But 1 or 2 days prior to the bone marrow, the child had received a single dose of dexamethasone before the initial bone marrow was done. So there were numerous scattered macrophages with abundant vacuolated cytoplasm suggestive of macrophage activation or HLH. But the ferritins were in the range of 1500 to 2500 and the child was improving with antibiotics. We also gave the child IVIG. because we were not very keen to give steroids. Looking at the first CBC, it seemed like the absolute neutropenia had caused some secondary sepsis or infection. So we were not very excited to give steroids looking at the bone marrow report. Our main suspicion was the malignancy, but we could not find that. So we treated the child only with antibiotics, and later on we also added antifungals, and we gave an IVIG cover as well. The bone marrow biopsy also suggested the same thing, hypocellular marrow with increased macrophages and lymphoid cells. So because the story was very unusual, atypical, and there was no malignancy in this story, we thought, could this be a primary HLH? We were not sure. So we sent a whole exome sequencing, and we were advised by the lab that at least 1 week gap should be done before the PRBC transfusion, which was given on admission. So with a hemoglobin of 6.3. While she was in the hospital, we also worked up for other etiologies. So the EBV, the viral markers were all negative: EBV, HIV, CMV, and hepatitis. We sent the perforin assay, which was normal, and the whole exome, like I said, was sent. Immunoglobulins were in the normal range. Echo, X-ray, TB gold was negative. Initial ultrasound neck just showed cervical lymphadenopathy. Ultrasound abdomen was normal. So as you can see, day 1, day 3, and day 7, the hemoglobin was stable after PRBC transfusion. The WBC count started improving. The neutrophil count also started improving, and the platelets were stable. The CRP started coming down, and the procalcitonin also. The ferritins never went up really high, so like I said, that's why we didn't give the child steroids, and we wanted to see how the child does without steroids. And the fibrinogen was normal. Triglycerides were also normal initially. But the story changed in the next 10 days. So what happened was, 1 second, yeah. So the child developed a the swelling in the neck increased, and when we repeated the ultrasound of the neck, that showed some collection with the cervical lymph nodes, for which the child the child had an IND, and the cultures were sterile, the CB-NAT was negative. We were also thinking if this could be TB related because the child must have got some infection. The KOH stain was negative, and the lymph node biopsy surprisingly also showed signs suggestive of HLH or macrophage activation syndrome. Now, if we look at the different CBCs, we can see that the neutropenia started developing again. And since you can see from day 12 to day 19, there's significant neutropenia, and the platelets started dropping. And the CRP was never negative, but it was fluctuating between 40 to 90. And the ferritins again never went above 5,000, 10,000, not on those ranges, but the triglycerides were high. The LDH was normal. So the issues were that whether the child has gotten another iatrogenic infection, because child also had a PICC line, and the second blood culture showed Staph aureus. Our hematologist started the child on GCSF on day 10. And these are the CBCs in spite of GCSF dosing. So the child had received meropenem, amikacin, ticoplanin, fluconazole, IVIG, and GCSF. And that's the time we started thinking if this is all HLH associated, and should we be brave enough to start steroids because of the risk of sepsis anyway, because of the febrile neutropenia. And this was the last CBC on your right, which shows the neutrophil count of 0. I think this was the CBC for 2 consecutive days, before which the child was transferred to Gangaram Hospital. So issues at the time of referral was that the neutrophil count was not improving at all. The low grades fevers were persisting with the CRP being positive, and the child was started on 10 mg per meter square DEXA, 1 or 2 doses before being referred to Gangaram. And our differentials were, of course, the child had febrile neutropenia with secondary sepsis. But initially we thought, because initial CBC is also from March to June, had a gap of 3 to 4 weeks, we thought, could this be a congenital neutropenia syndrome or a cyclic neutropenia? Could this be primary HLH beyond perforin, or could be some other immunodeficiency? And the last was like a rare, some other autoinflammatory, which we were not sure which could this be. And so the case was transferred to Gangaram Hospital, and I think that's the end of my slides, and they'll continue the case from there.
So thank you, Abhay, for presenting this very challenging case. And you had already worked up this patient so very well that, Dr. Sujata and myself really didn't know what to do further for this child. But we initially just stopped the steroids. We wanted to see how the patient was behaving. And I'll request Dr. Mridna now to present the Gangaram story for this child as to what all happened with us and what all we did while managing this case. Do you want to share, Mridna, or you want me to
Yes,
share?
ma'am. Sir, I had actually sent a request, but it was denied.
Which one? To share?
Yes, sir.
Okay, let me share.
No, we can see your screen.
Uh-huh.
1 second. Okay, yeah, we can see your screen now.
So, at presentation to Gangaram Hospital, this child had high-grade fever spikes, and she also had this maculopapular rash, which was mainly over the back. She did not have any lymphadenopathy or hepatosplenomegaly or swelling over the philtrum. She had profound neutropenia at admission. ANC was only 56, and blood culture showed Enterobacter and Pseudomonas. So basically, this is a 16-month-old child with who is developmentally normal with no significant family history, presenting with persistent severe neutropenia. She did not have any organomegaly, and she had recurrent infections with Staph aureus being documented at a previous hospital and Enterococcus and Pseudomonas at our hospital. She also had high inflammatory markers. So at this point, we worked her up like we would any case of neutropenia relevant to her age. We consider the possibility of acquired causes like infections or nutritional, but MCV was normal and the peripheral smear did not show any typical features of megaloblastic anemia. In addition, the levels of vitamin B12 and folic acid were also normal. We also sent viral PCRs, which did not show significant copy numbers. We considered a possibility of infiltration of the marrow by primary HLH or hematolymphoid malignancy. For this, we did a bone marrow aspiration and biopsy here after stopping the steroids and Nukind for a couple of days. We also sent the biopsy blocks from the previous bone marrow for review at our hospital, and both of these did not show any evidence of abnormal cells. And there was histiocytic predominance, but only few cells showed hemophagocytosis. So we also considered a possibility of congenital neutropenias. The bone marrow aspiration or biopsy did not show any evidence of maturational arrest, and there was no response to GCSF. We also considered other PIDs, but immunoglobulin profile of the child was normal and there was no lymphopenia. Whole exome had already been sent and that was awaited. Then we also considered a possibility of macrophage activation syndrome in view of high inflammatory markers, high grade fever, rash, and keeping the age, very young age in mind, there was always a possibility of autoinflammatory syndromes. So we also considered immune mediated cytopenias and we planned to send anti-neutrophil antibody. So at this point of time, we were really in a dilemma as to what exactly we are dealing with. Are we dealing with a hematolymphoid malignancy? Two marrows had not shown any abnormal cells, but both of these had been done after steroids. Then are we dealing with a congenital neutropenia? Marrow did not show any maturational arrest and there was no response to Nukind, but this is also a possibility. Then are we dealing with a PID or are we dealing with HLH mass spectrum, keeping the high ferritin, triglyceride and inflammatory markers in mind? So, as we were stuck, the child had been given sensitive antibiotics, and despite that, there was no response in fever. There was minimal response to minimum improvement in cytopenias. So, we were really stuck. And at this point of time, we keeping a possibility of HLH slash mass in mind, we started the child on anakinra, and there was a dramatic response to anakinra. The fever resolved within 12 hours and rash also improved within 24 hours. So at this point of time, we
And the
got this.
neutrophil started rising. And the
Neutrophils also
neutrophil
started to
started
rise.
rising. So we thought, bingo, this anakinra really worked and did the magic. And that is when, the exome that Abhay had sent came up with this report. And
So,
Mridna, do you want to just read it out
yes,
for
sir.
everyone? Yeah.
So this whole exome report showed an NLRC4 mutation at NLRC4 gene at exon 4 at 1331 codon, which was heterozygous, and this is known to be associated with familial cold autoinflammatory syndrome type 4, and it is autosomal dominant inheritance, and it was classified as a VUS. So we sent the Sanger sequencing of parents at this point, and we also started the child on sirolimus with therapeutic drug monitoring. The child was very well at this point. She was not spiking any fevers, and neutrophils had started to rise. So we discharged the patient at a neutrophil count of around 500.
So from 50 to 500 without any steroids, without any other medication, just with anakinra and sirolimus, this child had an excellent response, and the fevers that were going on for these weeks together completely disappeared. But we were not sure of this report. And at that point of time, Dr. Sujata spoke to Dr. Pallavi and to get a kind of a understanding about this kind of a report. So Dr. Sujata, do you want to comment on what was going on in our mind at that time? Are you there, Dr. Sujata? I can't hear you. You're muted.
Yeah, so sorry about that. So yes, so at this stage, we thought that this patient could have an inherited inflammasomopathy, and that was driving this abnormal phenotype of this patient having spiking fevers with significant rashes and cytopenia. Some of these features had been described with this particular inflammasomopathy, and we deferred to Dr. Pallavi to take us forward on this journey of what this VUS meant and how we could consider that this was actually pathogenic for the given patient, and this classification wasn't as sensitively done as it should have been. So over to Pallavi.
Thank you, ma'am. So, you can view my screen.
Yes,
You can
very
see my
well. Thank
screen?
you.
Yeah.
Yes.
So I will first start with outline of my presentation would be I'll touch some basics about genetics, then go to how I'll read a genetic report, introduce few criteria or the guidelines for ACMG that we use normally to classify these variants to gain more evidence if it is disease causing or not with the available literature. And then the two cases that have been described, we'll just read those reports using these guidelines and try to interpret it. So the very basic human body having cells, just pointer, cells, nucleus, which contains chromosomes. Chromosomes have densely packed DNA on them, and a segment of DNAs will form genes. This DNA is double helix and it has these 4 nucleotides. Double helix, it has 3' to 5' end, which is an antisense strand, which is used as a template for the RNA, where a complementary mRNA is formed. Whereas for the DNA 5' to 3' strand, it's called as a sense strand, which is complementary to the mRNA strand, except that the thymidine is replaced by uracil. So the DNA undergoes transcription to form mRNA, and mRNA later undergoes translation to code these proteins. So these bases form a group of 3 known as codons, and these are the table that is available, which you can, if you ever want to go in depth of this, use. Like the first base here is UAC. So the first base is U, you go for U. A, you go for this table, and the C is here. So this UAC is translation protein is tyrosine, and so on. So this is how a protein is formed. This is one concept I want to explain only for the reason this word transcript is something you will see in the reports, plus when I talk about it briefly about where it's mentioned in the report. So the DNA, it is transcribed into RNA, but this RNA, as you see, this exon 1, 2, 3, 4, 5, it undergoes a process called alternative splicing sometimes, and they combine in different forms. Example, exon 1, 3, and 5 can combine and translate to form one particular isoform. exon 2, 3, 4 can combine and form a second. So it's not necessary that they will combine all the exons together. That's number one. It's not necessary that will always be in a figure of 3. In this example, it is combining 3 exons, but it can have varied lengths. And all these causes different protein to form. And these proteins in our body means a single gene can produce different types of proteins, which we call as protein isoforms, which can have similar or completely different functions in our body, binding properties or enzymatic activities. Just to give an example, is this calcium gene, which in thyroid gland, this gene secretes calcitonin, which will regulate our blood calcium levels, whereas the same gene, the protein isoform that it secretes in the brain, it gives rise to calcitonin G related peptide, which acts as a vasodilator and pain modulator, just suggesting that the same gene can have different protein isoforms, which can cause different functions. So just briefly, what common genetic test we ask? One is the whole exome. It's like the whole apple that we are going to see, and try to sequence. Next is the whole genome. There's a whole exome, which is just the 1 to 2% of the genome. And as we just discussed yesterday in the meeting, the whole exome is not strictly related or restricted only to exome. It does cover some 10 to 20 base pairs of the intronic region too, because mutations in these regions can also be disease causing. And the third other common is a targeted sequencing, where we look at a specific region of the gene or specific gene or a mutation in particular. And that's where we design our different panels, example for immunodeficiency, for cancer panels, etc. Or Sanger sequencing, when we already know a variant and we just want to check that in the parents or the siblings, we just see that one single variant. So next, let's read a genetic report. So this is how, and this is the same case 2 report that I have picked up as an example. And I'm going to divide it as a column 1 to 7, and pick up the columns each to just understand how to read it. So in column 1, NLRC4 is the gene name. The minus that you see here, it stands for the antisense strand. So that is the complementary mRNA will be formed. So this gene is present on the antisense strand. This number, or this is a transcript ID. So if you ever want to read this gene in detail, you visit the websites. There you will see there are different IDs for this transcript, and they have different protein sizes. So you have to pick up the relevant one from your report to study it further. Coming to column 3 and 4. So this is the exon. Everything that's labeled 1 to 9 is the exon, and in between is the intronic region. And then how do you read a variant? Very basic. C is for the coding DNA. It's a DNA level substitution, where 1331 is a nucleotide position and adenine is replaced by guanine. Whereas at the protein level, the lysine is the reference. That is the original, or the human, in healthy individuals, lysine is present at 444 amino acid, whereas in this patient, it is replaced by arginine. Coming to the column of zygosity and inheritance, I'll read it in parallel. So if it is heterozygous, it leads to autosomal dominant. If it is homozygous, it is autosomal recessive. If it's compound heterozygous, same gene, 2 different mutations, one like each coming from different parent, one from each parent will lead to autosomal recessive. And if it is labeled as hemizygous, it is present on the X chromosome, so X-linked. Here the females will be carriers, whereas the males will have the disease. Other 2, commonly we encounter these words, autosomal dominant negative, because these are heterozygous mutation, and these are at the functional level when we see, okay, this variant is just reported as heterozygous, but is it actually disease causing? Because that's not what's described in the literature. So I'll just familiarize with these 2 concepts. One is autosomal dominant negative. Here, if you have one is a mutated allele, the other is an unaffected allele. But here the mutated allele interferes with the function of the normal protein that is secreted by the unaffected allele. Whereas in haploinsufficiency, the single unaffected copy, the amount of protein that it secretes, it's not enough for the normal function of that particular gene. Column 5 is according to OMIM, what is the phenotype or the disease description, be it in humans. And if you just scroll down and go, what is available in animal models or in literature is briefly described in this website. And classification, so this is classified as pathogenic or likely pathogenic based on functional validations that are present in the literature or according to the ACMG criteria. Or if there is no evidence, if it's a novel variant, it will be labeled as a VOS, and down they'll just write this PM2 or other criteria that they fulfill, which are as per ACMG. So just going through, when we see, what are the possibilities when we see a genetic report? One is either we have a pathogenic or likely pathogenic variant. Our phenotype is matching. So we have a direction of treatment, how we counsel, how do we prognosticate. But if the phenotype is not matching, what do we do even with these pathogenic and likely pathogenic variants? One is I would go back to look if the patient has any subtle phenotype that's present, or there is any pleiotrophy. So pleiotrophy means a single gene can have different phenotypes. For example, a patient who might have a gene for Marfan's might just have a dislocation of lens, but no other symptoms. Or a child with sickle cell anemia might just have anemia for the presentation, but no crisis, no stroke. So they might be the subtle findings might still be present. Or there might be phenotype in evolution. So we have to keep a watch. And there is one more thing called as secondary findings. So according to ACMG, they have a gene list in which whenever we are doing a VES for any condition, be it even if I'm sending a VES for a 2-year-old suspecting an autoinflammatory disease, but in that child, they identify a pathogenic or a likely pathogenic gene. Example in BRCA gene, which is known for cancer in future. There is a rule in some countries to report these findings, whereas in India, it's not mandatory. And example, like in MedGenome, how I know, when you're filling the form, you have to tick on that form specifically if you want to know these findings. But again, how you deal with these findings is another story. Next is you're highly suspicious that the patient has a phenotype which is looking like inflammatory or the disease that you're suspecting, but there are no variants that are identified. So you should look down in the second page of the reports. Many a times they'll write suspected deletions or suspected duplications, and the method that is used, be it VES, be it NGS, is not an accurate or a gold standard to detect these, and you might need next level of tests like microarrays or Fisher, depending on the deletion or duplications or other findings you have. Or there is a possibility of a new gene discovery. Next, the challenging one is a variant of unknown significance. If the phenotype is not matching, we just wait. But if the phenotype is matching, here comes the issue of how we're going to counsel the family and how we're going to treat, given the resources that we have. We can't be doing functional validation, even if the phenotype is matching for every variant we have. So taking the opportunity, like what I learned in the Kastner lab in 5 years was principally, if there was any new variant identified in a new gene, or if there was a new gene identified, what are the points that you will analyze and evaluate those variants to make sense that, okay, can you go ahead and try to functional validations or just discard it? Because in huge databases, you identify many such variants and many more genes, and you can't be working on all of them. So I'm just going to pick up few points from that and try to like give an example about how we interpret these two reports, VUS's reports from the previous two cases. So of the big list, I've picked up these 9 features that we will assess for these two VUS's report or the cases that we have. and try to see if we can classify it better or it still remains a VOS. So first is gene disease association. So is the gene already known to cause any phenotype? So is it already a known disease causing gene, be it whatever phenotype in literature? That's one question. Second is, does this gene lie in any critical domain of the protein? That's number one. Or is there a known hotspot? Example, if our variant, where our variant is present, is the neighboring area also having variants described in literature as pathogenic or not pathogenic? Means if it becomes likely chances that our variant is significant. The other way, if the area surrounding our variant has more of benign or likely benign variants already described in literature, it's low threshold, or you would think that it is not disease causing as one of the criteria. Third, what is conservation? So, as in the evolutionary tree, example zebrafish, mouse, bovine, human. So, the part of the genomes sometimes the remains constant. Example, if in this NLRC4 case, if I use as an example, if lysine is present at protein 444 in all these organisms in the evolutionary tree, that would signify that it has an important function for the biological life and it is conserved across all these species. So that's as a positive point. Whereas if it is not conserved, example, in one species it's lysine, other it's arginine, other it's glutamine, means it doesn't have that important function. Next, coming to amino acid chain. So these coding amino acids, some are positively charged, some are negatively charged, some are neutral, some are heavy or light chain, some are polar, hydrophobic. So the properties of amino acids, how they interact, because in mutation, one is replaced by another. So what is the change in the physicochemical, which normally the ideal way is to go through structural remodeling and then doing proteomics changes. But how much we understand looking at the structure that we are going to see as an example. Next is population frequency. There are websites where they have sequenced like Nomad, Genome, TopMed, all these, where they have sequenced healthy individuals. So we have genomes from the individuals. We check our specific variants. How is it represented in these populations? If it is frequently seen in this healthy individuals, so it's not disease causing likely. But if it is very rare or absent, then it gives us a point, okay, it might be disease causing or an important variation, which is contributing to as one of the evidence. But the challenge in this is, again, many of these population websites, databases, they very poorly represent the Indian population. So at least in my personal practice, when we get reports, I look at what they mention in the internal database. Example, if I'm sending to a lab in India, they are going to check that variant across their whole database and report is it frequently seen or not. So that is very standardized, even if the group is small, very standardized for the Indian population. Next is the in silico predictions. So these are some computational tools which again use some of these features, they club together, and then it's a bioinformatical tools which you have to just key in your variants and they tell you whether it is damaging, tolerated. Does the patient phenotype fit the picture? Do we have any segregation data, like is it a de novo or it is inherited from the parents, and if any functional assay is available? So these are the 9 features on which I would build on the next 2 cases. And to build those cases, now this is an important article for ACMG and AMP, which talks about the standards and guidelines that they use to interpret any variant. It's a very text heavy article and I can circulate this after the meeting. It's a huge and very text heavy. So for just a glance, I'm just, so that it's not foreign, the step 1 is the criteria. So this is that PM1, PM2, etc. that you read in this VOSS reports. So you can read this in detail, maybe when you are reading on your spare time. Second is the evidence. So you use those PM2, PS4 criteria, etc., and apply on these. Third is you combine this PM2, PM3, etc., and then you say whether these variants are pathogenic, likely pathogenic, benign, or likely benign. And if they don't fulfill any of these, means it's a VOS. It's very text heavy, I know. I can share this article, but I'm going to try simplify this for our two cases. So, okay, first I've taken the NLRC4 case. So when I was introduced to this case, the story that I had was febrile neutropenia, nodular rash, had macrophage activation, gram-negative sepsis. And so early onset severe systemic disease. So WES was done, which was a heterozygous mutation in NLRC4, which was classified as a VOS. So I'll just key in the results. So first, is the NLRC4 disease known to have this feature? So it's a gain of function is reported. It causes inflammasome activation, leading to IL-1 beta and IL-18 production. It does cause systemic inflammation, mass, and has heightened response to gram-negative organisms, especially to flagellin and type 3 secreting protein. So this NLRC4 is heightened to these infections. Next, I just checked then where does this lysine 444 protein lie? So this is the protein structure of NLRC4. So these are the three important domains, and these numbers that you see are the protein numbers. So protein 1 to 88 is the CART domain, 163 to 457 will be the NBT domain, and our variant 444 lies in this domain. Then I went in the literature. So in this paper, I came across two findings. One is two neighboring mutations, one in this histidine 443 and serine 445. They both have been described as pathogenic as Clenvar, and our variant is lysine 444. So it's lying in between these two. That's number one. Number two, if you see in this NBT domain, there are many loss of function disease causing variants identified. So this I would call as a hotspot for this particular variant. So it is in the hotspot region. And I went ahead to see, okay, what is the phenotype for these two patients at least? So they did have fever and rheumatological and dermatological. So phenotype was FCAS like familial cold autoinflammatory syndrome rather than MAS, but they did have these features. Next, I went to look at the conservation pattern in this. So here we see that this case, the lysine, so it is well conserved amongst rat, mouse, humans. Coming to lysine, which is changed to arginine. So lysine has a small amine group, whereas arginine has this heavy guanido group. So they have more of hydrogen bonding and might destabilize because it's a bulkier protein. But these are all hypotheses which can just be proven with structural remodeling, and then next step is proteomics. Coming to population frequency, so it was not reported in these websites or databases, and in the internal database also it's not reported. Coming to this computational tools in silico predictions, by Swift it was damaging. CAD is one score, which is 19.75. So usually after 15 or 17, we consider CAD score of 15 or 17, we consider that it might be disease causing. But by Polyfin, it was benign. My next criteria was, does it fit? So that time I thought, okay, it's early onset febrile illness with mass phenotype, with fever, neutropenia, high ferritin, elevated triglyceride, had elevated fibrinogen, but which I attributed to maybe it's an acute phase reactant because it's IL-18 mediated, suspected, and the additional gram-negative sepsis due to Pseudomonas and Enterobacter. So this was my interpretation of how it fits into the phenotype. Segregation was pending then, and functional studies were not available, or we had not done till then. So if I have to summarize, so is there a gene disease association? It's yes. Is it in the functional domain and in the hotspot area? Answer is yes. Is it conserved across species? Yes. Does the amino acid chain seem significant? Likely significant, because that's only on the structure that we can read now. but we need more evidence. In silico predictions are conflicting because some say disease causing, some say it is benign. Population frequency, it was a rare variant. The phenotype did fit, and we didn't have segregation or functional assay data. So I've just clubbed these color coded, like in disease association functional domain, to just say located in functionally relevant domain and so on, so that I can give them the category like that PM2, PM1, etc. And this is what, using those heavy text tables, I have labeled, which you can go back and read. And using this criteria and the description of the criteria, the evidence that we can collect, one is it's absent or extremely rare in controls, it's PM2. So if you see absent in population database, so it gets a moderate evidence. Second is located in functionally relevant domain or in the hotspot, it is PM1. So it gives a moderate evidence. Phenotype is highly specific to the gene, that is NLRC4. It is a supporting evidence. In silico, because it was conflicting, I just kept it BP4, so that just being benign supportive. And these two, we don't have evidence, but in case if we had functional studies suggesting of IL-1 beta or IL assays suggesting inflammasome activation, it will be a strong evidence, as you see here. Or if we have a Sanger's report and if we see it's a de novo occurrence, again, it would be like de novo paternity, maternity confirmed, it would be a strong evidence. Whereas if it is autosomal dominant, it is present in maybe either of the parents and one generation above. So, and they are affected. So co-segregation with disease in multiple affected will give them a different criteria, and that comes in supporting. So this is the summary. We had 2 moderate and 2 supporting, and this criteria this evidence doesn't fit anywhere in pathogenic, likely pathogenic, benign, or likely benign, and hence it is given as a VOS. Can we reclassify this because we have Sanger sequencing available to us? So in case in Sanger's, it comes as a de novo. So we can give it as a PS2 strong, as I just showed it in the last slide. Or if we go back, if either of the parents have it and they are affected, which I don't think they have a family history in this case, but if we go back and if they had that evidence as an autosomal dominant and the mutation is present, it would be a supporting evidence, and that would change it to likely pathogenic. Because see, likely pathogenic, it would be 1 strong if it is a de novo, and we already have 1 to 2 moderate evidence. So that's how, using these criterias, we can at least try to see if we can at least, what is available to us. Sangers are possible. Coming to functional data, even though it is like a strong evidence, we do have limitations about where to do it, how to do it. And if you have a functional validation, it directly jumps to either pathogenic or likely pathogenic, depending on what the functional data and how strong the evidence is. So I think Sanger sequencing for segregation in such cases should at least be attempted with the resources that we have. So the next step that I had mentioned then was, it's currently a VOS, but phenotype supports the pathogenicity, and the child has to be treated as NLRC4 autoinflammatory disease. Anakinra and mTOR inhibitor was started, and parental testing, it's highly chances that it might be a de novo. I don't know still the answer for that, because the child has very early disease and severe presentation. So unlikely that one of the parent might have and be asymptomatic for so long. And next is if the function studies are available or any collaboration is possible. So that was my understanding for the NLRC4 variant. Coming to the second, to summarize, it's a 11 years old female, born of a consanguineous marriage, recurrent episodes, bone pain, swelling, acute phase reactants, blood counts normal, has CRMO-like picture, but atypical finding of diphthal involvement and high phosphorus. And the West was showing GALNT3 homozygous mutation, which was a VUS. So again, we'll just fill in the results for these specific features and see if the classification changes or still remains the same. So as ma'am has already described, so GAL entry is described in literature. It has two phenotypes. One is hyperphosphatemic familial tumoral calcinosis. Next is hyperostosis hyperphosphatemic syndrome. And so this is the protein structure. These are the three domains of this protein, and our mutation arginine 162 is outside this domain. And if I go back to the literature, so in 2012, like 2010, there was this one case report of one individual who had a homozygous mutation in the same gene, like arginine 162 to glutamine, who had painful soft tissue masses, hyperphosphatemia, and skeletal radiographs did show some calcified mass. So in short, the mutation R162Q is already described in literature to have a phenotype of tumoral calcinosis, while our patient currently at least just has the bone findings, and I don't think the soft tissue findings yet. And this is the summary of the mutations that are already described in literature in this gene. So just to look at, this is our area, like R162Q. It is outside this domain. There are very few mutations that have been described around this area. So it's not very like sure that, okay, it can be disease causing, because if you see this domain, it has so many disease causing mutations. And the mutations that are in black are reported to have tumoral calcinosis. In blue are the hyperostotic, hyperphosphatic bone, and the green one has both, while the red one is high bone mass. So here, another interesting thing is that the R162X is the stop codon. It's a nonsense codon. It's already described in literature as causing tumoral calcinosis. And our mutation is also in the same place, but it is a missense mutation. That is, arginine is replaced by glutamine and there is no stop. So we don't know the significance about the domain or the hotspot region for this variant. Coming to conservation, so in mouse, rat, bovine, human, this arginine is conserved across all these species, suggesting that it is important for some biological function. Here, the arginine is replaced by glutamine because of the mutation. So this is a very bulkier guanido group, which is replaced by these tiny group. And again, it just, if you try to put in structural remodeling, it's more about that it is a bulkier protein. So there's going, which is replaced by a smaller one. So it is going to destabilize the protein, or it's going to create more pockets or reduce hydrogen bonds. So basically it looks like a significant change, but I will not go into details of that. Population frequency, it is not reported in 1,000 genomes, but it is very like less frequency. It is known in other websites and including the internal database. But the in silico predictions, everything was suggesting that it is disease causing or it is damaging effect on the individual. Does the patient phenotype fit? Bone pain, swelling, hyperphosphatemia, radiographs having multifocal marrow and periosteal changes, especially diphylyl, yes, it does fit. Segregation was pending and functional is not available. So again, to summarize, do we know that this gene causes disease? Yes. Functional domain involvement, I'm not convinced given the location and it's not in the hotspot. Is it conserved? Yes. Is the amino acid change significant? It looks like. In silico prediction, it's disease causing. Population frequency, it's rare. Patient phenotype does fit well. Segregation and functional assays are not available. And I've just grouped them together for ease of giving them again the criteria. And I've given these criteria based on those heavy text 2, 3 tables that's there. And we'll just go through the evidence. So again, it is absent or extremely rare in controls, which gives it the PM2, which is moderate evidence. Phenotype is highly specific to this mutation. So PP4, which gives it a supporting evidence, patient's phenotype or family history, highly specific for gene, and that is a PP4. In silico predicts a deleterious effect. So that again is a supporting evidence. Now, reported in affected individuals, why I have colored it different is we just have n is equal to 1. So even though it is present in literature over these 15 years, there have been no more case reports or functional studies done for those variants. So I have my reservations about giving it a strong criteria. But if we had more reports, I would have given it a strong criteria. Segregation, if we see that both the parents are heterozygous, we confirm that it's a recessive disease, it is moderate evidence and functional. In case if we have, it can be strong if it is showing a loss of function. If it shows equivocal, then our evidence changes to different criteria. So using only these 3, we have 1 moderate plus 2 supporting, and that's why we have a VUS, because this combination doesn't classify as pathogenic, likely, pathogenic, benign, or likely benign. So does our Sanger sequencing help us to reclassify this particular variant? And if the segregation confirms that it's an autosomal recessive, like both the parents are heterozygous, it will give me a moderate evidence. But still, 2 moderate plus 2 supporting is still a VUS because it doesn't fit any of these criteria. Should we consider the PS4? PS4 is this one, that n is equal to 1 was the question, which is again, it all depends how you want to weigh it, depending how the patient is doing and what is the clinical phenotype. And because if you weigh in PS4, then it directly jumps to likely pathogenic. If I give importance to that n is equal to 1 case reports that describe. So in summary, it is currently a VUS and the phenotype is matching. And rather than, as ma'am mentioned, using steroids and methotrexate, if we have this much evidence, if we consider that n is equal to 1 who responded well to treatment, if we consider that as significant, we can definitely treat this child as HHS, and parental testing will definitely help us further characterize it. So my key message is genetics and immunology is definitely shaping the future of rheumatology. VUSs, the phenotype and the supporting evidence, what I just showed, will help you. But again, it's an informed decision that if you want to treat, if it's matching everything, or weigh advantages and disadvantages of the treatment, because we have limitations doing functional assays. Next is we need to maintain a database where we periodically review this VUSs. Ideally, it's the companies where we do these tests who are supposed to let us know if the VUS is changed to likely pathogenic or even likely benign or benign. They are supposed to inform us, which I don't think happens. So we should maintain and periodically review this data. And banking definitely leads to new gene discoveries, because this is what I've seen and learned in the Casna lab. I would like to thank Sujata ma'am, Manas sir, Abhay and Manjali for giving this opportunity and involving me in this patient's care. And definitely Kuchandani sir, who's my mentor, my guiding force. He's the person introducing me to rheumatology, guiding me at each step. And Dr. Kastner, because of whom I had this opportunity to learn this unique thing which I can implement today in the clinical practice. He's a gem of a person, an extraordinary person, being like a very particular and a patient with all the work that you do, because I went there as a clinician, but when I transitioned into going into a lab, I went as a clinician but came out as a researcher. So that's all thanks to Dr. Kasna and Ivona, obviously. She is a mentor, but she prefers to be called as a friend. She'll never let you miss home. So this is the image that she has hosted my baby shower at her house. She is very kind, overwhelming. Thank you, everyone. And I am okay to take any questions.
So thank you, Dr. Pallavi. While it is very complex, it is really very interesting, and I think we all have to learn a lot from you and from our geneticist colleagues, because this field is rapidly evolving,
Yeah.
and I think you have given a very important message for the companies to be on toes and to really do justice to our patients by updating what is happening. And I think that's a if all of us clinicians give that message to them, they will be on their toes, and they will deliver what is really expected out of them. So Dr. Sujata, do you want to give some comments on this particular patient? Up till now, you have given this Anakindra, the child is better and things are good, and Abe is relieved that finally we have an answer. Do you want to comment on any of these things that have happened up until now?
So I think that I have a couple of questions, Manas, before we go back to our little baby, the inflammasome homeopathy. I have a couple of questions, Pallavi. Now, for example, our patient, the child with the bone inflammation, has a specific mutation in the genetic pathway that is driving abnormal phosphorus in the body. And we only have case number one, only N of one in literature. Now, here's my question to you, that this data, clinical data that we have fed to the company, and the discovery of this mutation in the child that fits very well with the GLNT3 mutation, how does this get on to the databases that would be searched for in future? How do we add this number 2 to the 1? Is it only with a publication in an index journal, or is there a system where these genetic abnormalities across the world have to be pooled, so that, if, for example, you have 20 patients more who are not reported, then there's no doubt that this is
True.
a disease causative gene.
Yes, ma'am.
How
I
does that
completely
work?
agree. So it's either publications or websites like Clinvar, or if
How
it's
does this get into
auto-inflammatory, then
that?
you submit. Ma'am, that we have to get in touch with the Clinvar people. So if you go on the Clinvar website also, you see that submitted by this on this date, and this is the variant. Some people do provide phenotypes, some don't provide. And then they see if the evidence changes or it is conflicting still. But definitely, these are current companies. Commercial companies will not do that. That job is for us to add it to the respective websites or as a publication.
So I think that this in itself is a very big jungle, because
Yes,
we don't have the genotypic abnormalities in the international databases that are housing patients, for example, from Philippines or
true.
Singapore, Malaysia. I don't know what is the legal standing here, and it is these patients who really suffer because we don't have the functional abnormalities. So maybe that as a group, even say pediatric rheumatology, say we can even begin with India, if we can just pool our data from a company and list out our abnormalities, which is then published, that in itself is amazing.
Yeah, ma'am. That's true.
And the second
So I
question I
had,
have is,
yeah,
sorry,
ma'am.
sorry,
Yeah.
no, after you.
So one more thing, like when it comes to this company, so I did speak to one of the companies because we're sending all our samples, that could they help us if we have any variant that we find to run through their internal databases, because they are very specific to our population. So we understand whether it is rare or not. But they do have restrictions and limitations even on those. So nothing is open or that easily accessible as of today. Maybe it's even on the personal relationship or what collaborations you all have, like in writing, but it's not like a simple story that they would want to help you find the frequency.
So when you say that this is not reported or reported in a frequency of 0.00x, what is the number, which is the magic number, which says that this is present significantly in the normal population or not? Or does that depend upon the gene?
No, so when I because I am more conservative trained more to look for the new gene than the already described. So the cutoffs that I use is for heterozygous, it will be 0.0001%. If it's homozygous, it's 0.001. So it's very specific to what inheritance and what pedigree you're looking at. You're thinking it's dominant or it is recessive. That also plays a very important point to set your targets about what frequency, is okay. And if you go on Nomad, or maybe, sometimes I can just show those websites, run through pages. So they will write there, how is it like what it might be present in heterozygous state, but in the homozygote, it's 0. But if we are looking at a homozygote, for us, it's a good moment because there is not reported in a homozygous state in the healthy individuals, means it's not coming from their parents. So all these small points we need to consider. That's why starting from the pedigree becomes very important when we suspecting, okay, what type of disease are we suspecting?
And also, it may be a very dumb question, but would it be a correct assumption that a homozygous disorder would usually be inherited, whereas a heterozygous one may be a de novo mutation, a higher chance?
So that's, ma'am, almost always correct, because autosomal recessive has to come from one of them. It's not going to skip any generation. So be it in a compound heterozygous state or it comes just as an homozygous, autosomal recessive will come from either like one gene from the parents, one variant from the parents. Autosomal dominant, some diseases do have, like, they skip generations, they have variable penetrance. So that's the tricky part, because many a times you'll see, okay, we have this variant in the proband, but father just has one single joint. How significant is that joint swelling? We don't know. He had it, went off. So this time, then it becomes important to go through father's pedigree. So it becomes very complex with autosomal dominant compared to autosomal recessive. I feel in my personal in interpreting these reports. If it's a de novo, okay, it's, easier. But if it is coming from any of the relative, then going ahead one pedigree up, like one family up, sampling again becomes more relevant if you're confused. And that's
I,
very challenging for our population.
I understand. Anyway, thank you so much, Pallavi. I think you're a great resource for all of us who struggle with these genetic reports, and I think we should
You
really
might be
encourage
bombarded.
collaboration.
You might be bombarded with a lot of emails and a lot of VUS reports, and I'm sorry for that, but that really, gives you a platform to really shine in India and interpret these reports for all of us who
All of
have,
us, I think, yeah.
yeah. I just wanted to comment that for the second case, which was the child with the NLR mutation, the parental Sanger sequencing was normal. So this really was like a de novo heterozygous mutation in a child. And you did say that if this is absent in the parents, this becomes even more significant in the child, and when it fits into the clinical criteria. But, I would like to share with you and with our audience that this patient was very well on anakinra, on sirolimus, and for, almost 1.5 months was completely defervesced and was doing very well until very recently. This child presented to us with a very high white cell count. And we have done a peripheral blood flow cytometry for this because the cells had very blastoid morphology, and it later turned out to be a acute lymphoblastic leukemia B cell phenotype. And I don't have the full report yet because the family is still not consented for completion of workup and treatment. And we were, along with our colleagues, looking at reports of this particular genetic mutation predisposing for malignancies. So I really don't know whether this child had a malignancy, right from the start. And because of repeated steroids, we could not pick that right from day one, or whether it was really an autoinflammatory manifestation in a child, which led to a secondary development of leukemia, which is reported and is being increasingly reported. And I don't know what 5 years, 10 years down the lane, we will have information, whether we'll have more information for such a patient. So, it is acute lymphoblastic leukemia, and we are going to propose treatment on usual lines, and I would seek your help to discuss this further with experts across the globe as to how much importance we have to give to this gene, which looks like significant. And now that the child has a leukemia, and we would really seek your help for further management for this patient. So thanks, Pallavi. And
Thank you.
if Dr. Sujata would like to conclude this session, maybe by discussing the few questions that are there in the chat box with our experts, and then give some final comments, and I'll just shut my mouth here. Thank you.
Thank you, Manas. Pallavi, we have one question from Shama. The question is, what does it mean if mutation has single heterozygous variant? What if the mutation is on the sense strand? I meant plus besides the gene that is mutated. I
So
don't
that
understand the
just
question.
tells about, I'll just open. So what if, so first question, if it's on the plus sign, basically that plus or minus is only giving us a location about where is the gene located. That's why it is with the gene name. So that answers, I guess, that part. What does it mean if mutation has single heterozygous variant? Single heterozygous variant means heterozygous. In heterozygous variants, there is one affected, that is will be the mutant, while the second allele that we have will be normal. I don't know if this is clearly answered, but that's what I could understand from that question.
Yeah. And I don't think we have any more questions. We have a lot of compliments for you, Pallavi. So thank you so much. And I think we had a delightful session today, and we learned a lot from you, Pallavi. And I think that these cases show us that clinical medicine is dramatically changing, and teamwork wins the day. And it is that time has gone where we can be siloed in our own zones and, look at a few patients in the clinic and then carry on. Patient referral is becoming more complex. Families are more demanding. Medications are more expensive, and technology is ever expanding. And before we conclude, Pallavi, do you think that AI is going to help you to arrive at a more rapid conclusion as compared to currently what we seem to be doing is very tedious, isn't it? Is it done manually or can computers help you here?
So few things, example, the bioinformaticians can key in, because I don't know how coding, I've not learned that, but I know bioinformatician of the 9 points that I told. And when it comes to new gene discoveries, there are many more that you add to that list. Some of those data can be pulled using coding, which my bioinformatician friends do. But for me, because I don't know coding, I have to go through each one individually and
so very tedious, huh?
Yeah. And obviously, there are different websites that can help you, but then the licensing fee is very high, which was free at NIH. So it was very easy at NIH. But now, back in India, it's a little tedious and it's not like a minimal fee, and it's not one website. So it becomes very difficult. It's not like, okay, invest in one particular website that will help me. So, yeah.
We really need to have the government stepping in to take on the mantle of helping the children who are coming to us.
Yeah.
Otherwise, I think on an individual level, it's extremely difficult to handle these patients. So do we have any centers that are doing functional studies for particular genes? Is there any single referral point in India, for example?
So for this particular patient, we did try to send the functional assay.
NIH?
NIH Mumbai. They have the functional assay available for this particular gene, but unfortunately, and this has really never happened with us, but somehow I think it was the rain. Let's blame the rains in Mumbai. Our sample reached there in a not a very good condition, because those tubes are very specific. We got a courier from NIH to send the samples in those particular tubes. We did send the sample in those tubes, but the samples had perished by the time they could analyze, and we could not really do the functional assay. But we did the Sanger, which was negative.
So here, ma'am, I would like to add two things. One is the transport that sir mentioned. It's very difficult because it's very critical and time-sensitive samples. You will lose all the cells, like the important cells that you want to study in the transport, because it's temperature sensitive too. That's number one. And airport to airport, it's not that easy. Again. Second is, whenever, not any particular lab, but it's very important to have a very good number of controls, like a healthy control and even like a disease control, because your patient is only n is equal to 1 to understand exactly what's happening. So whichever lab is working, they should have like a balanced frame and that number of samples and individuals included in your functional assay. So interpreting the report in functional assay becomes also very important, not just, okay, the spike is more or the level is more, but exactly have they tested everything? That interpretation becomes very important, because we have heard a lot from Dr. Kasna when we used to screw up on this.
I
Yeah.
understand. I understand that we really benefited so well from your insights, Pallavi. And thanks so much. You've been so gracious.
you.
You've helped us out, put in so much of effort. And I'd like to thank MCure for helping us for this platform, and Manas for your absolutely excellent emceeing the whole show, Abhay for your case, and Manas for your fellow as well. And so thank you so much, everybody.
Thank
Good
you.
night. Thank you, Pallavi.
Thank you.
Thank you,
We
ma'am.
hope to
Thank you,
meet
Thank you.
again.
everyone.
Thank you, sir.
Thank you.
Bye-bye.
Thank you,
Thank you. See
everyone.
you.
Thank you, Pallavi.
Bye.
Good night.
Thank you, sir. Good night.